introduction on the group, but there are some things that we want to know which are more personal and therefore slightly intrusive, but I hope you will tell us about yourself. Okay, first of all, what is your favorite destination to travel in India?
Goa.
And for the alcohol or what?
I actually have a vacation, I have a second home there.
Arre wah. And you were born there?
No, no.
No, okay.
I'm a Sindhi.
Ah.
So I was born in Kalyan.
Okay. Education, school, college?
My father was a lawyer, became a judge, so we kind of went all around Maharashtra. As a result, my Sindhi vanished and my Marathi became very fluent. There are people who ask me, are you from Pune? Anyway, and unfortunately, when I'm in my clinic and an Ulhasnagar patient comes in and I say, sorry, meri Sindhi itni achhi nahi hai, and then the nurse comes in and speaks to me fluently in Marathi, it gets very embarrassing.
What is your education like?
So, MBBS and MD from Government Medical College, Nagpur, DM from JJ.
Okay. And which college did you like the most?
You can't ask that.
He is interested in end-of-life care. Have you made your own living will or advance directive?
Of course.
You have. Is it different, advance directive and living will?
Yeah, so, okay, we are starting on that. So when you make these documents, the living will is a document that kind of puts down your wishes. I don't want this towards the end of life, I want this. If anybody of you really wants to look this up, look up a document called 5 Wishes, F-I-V-E, wishes.org. You'll actually get a very nice understanding of how we should be thinking of this for ourselves. And the Indian version is available on multiple websites. There's one website, if you type in Vidhi, V-I-D-H-I, and Living Will, you'll get that. Or Pallium, P-A-L-L-I-U-M, and Living Will, you'll get that. So same thing. Sorry? So 5 Wishes is the international one, which is very good conceptually. It tells you how, what, everything. It down to what flavor of agarbatti I want. Literally. But for our purposes, a simpler one is the one that I'm telling you. This is the Indian one that we have aligned to what the Supreme Court has allowed us. Vidhi, Pallium, or IAPC. I'll give you 3 options. So any of these words, V-I-D-H-I, or P-A-L-L-I-U-M, or I capital, A capital, P capital, C capital. That's Indian Association of Palliative Care. You type in any of these and Living Will and you will get it.
And you, what about the advance directive?
Yeah, so now if you look at the Living Will basically has all these wishes. And the beginning actually was as a kind of a human rights issue. That, as medical science advanced, at some stage patients' rights started to drop off. So it was a human rights lawyer who said, I will make this contract so that patients put in advance what they would want and indemnify doctors against legal action. So that is where the Living Will began. The thing is, Living Wills began, and then people realized that you really, and as medical science advanced, you realize that there is a limit to all the material you can put in. कि मेरे को ये नहीं चाहिए, लेकिन मेरे को उसमें ये नहीं चाहिए, I want this flavor of ice cream. You can't do that. So what you realized is that you needed a person to stand there and take care of the nitty-gritty at the end. And that person may be given discretion or may not be given discretion. No discretion means मैं ventilator पर हूँ, निकालो, जाओ. Or discretion, check with the doctors, chance है क्या आने का, अगर आऊँगा तो will I come back walking, or will I be in this kind of a state which I don't want? All this discussion you can have with a given person. So what we recommend is that you also appoint 3 people. They are not a committee. So, एक नहीं है तो दो, दो नहीं है तो तीन. They will talk to each other. Obviously, they are people who will know each other, but they are three separate people and only one person makes the decision. Right? So that is called the healthcare power of attorney. Now you put the living will and the healthcare power of attorney together, that becomes your advanced medical directive. And all of this, you sign out with two witnesses and you just get it countersigned by a notary public or a gazetted government servant and it is done. What I tell people is that once you make it, make 5 copies, keep one with yourself, give one to each of your 3 healthcare power of attorney, put one in your medical records. If you want, put one more on the fridge door. Yeah.
Or on WhatsApp, so that...
Or whatever, wherever you put it. So this much, I think, anybody who's above the age of 60 should do. And you change it, you kind of review it every 5 years until you hit a stage where you know that the next 1 or 2 years might be your last, in which case then you're doing it every year.
Is it possible for you to give us an instruction thing, booklet or pamphlet on...
Yes, so when you go to that, you will see that...
On these sets.
Yeah, they have the FAQs also with it.
Okay.
Plus, for patients and all that, we are in the process right now of making a small cartoonized booklet, which hopefully will be free on the net. Aap log print karke, you can keep it outside. Beyond that, Hinduja hospitals, in the next maybe weeks or so, we will have a section where we'll be giving appointments for advanced medical directive, meaning people can come in and actually discuss with one of our doctors.
As a physician and who has seen so many bad deaths, so many painful deaths, for yourself, for your family, would you want the legalization of physician-assisted death?
I would want it.
Okay.
I would want my last days to be as much under my control as possible. But I realize that that is a political, legal, everything impossibility at this moment. Because a country has to go through this, the advanced medical directive stage. Then go through the evolution of palliative care, where we can guarantee you that at the end of life, provided you are aware and you can make your choices, you will not suffer. And people understand. In the UK, people understand that I will not suffer. Once you've gone through that stage, then the country is law-abiding, honest. People stop at signals at 12 in the night. When you get to that stage, then you will get this. So when will that happen? Achhe din kab aayenge? I don't think, not practically something that I'm thinking of.
Yeah. वो गाना था इजाज़त फिल्म में, सर मेरा कुछ सामान तुम्हारे पास पड़ा है, तो मैं ये कहता हूँ कि पॉलिटिशियन से कि मेरे कुछ अरमान तुम्हारे पास पड़े हैं, आएंगे दिन जल्द भिजवा दो, इंतज़ार में हम खड़े हैं, मेरे कुछ अरमान तुम्हारे पास पड़े हैं.
वाह वाह.
Sir, what is your favorite read? I'm going back and forth between academics for the moment. What is your favorite reading in non-medical area? Fiction, non-fiction?
No, I read
everything.
Everything. So, I mean, fiction little less, non-fiction more. I like reading some amount of economics, some amount of current affairs, some amount of science.
Yeah.
Evolution. There's no particular thing that
Do you watch cinema?
Very little.
Hear music, classical or Sugam Sangeet?
Both.
Both. Any favorite instruments, singers?
Singers, yeah, Manade and Mohammad Rafi.
Male singers?
Female, I would say there are so many songs of Lata Mangeshkar that I remember, especially from the 70s, when her voice was
best ever.
Like that. But then you also think of all those other female singers who never
rose because of that.
Rose.
Yeah. Do you sing?
No.
मैं अक्सर कहता हूँ कि I don't normally sing because I don't sing normally. How many languages do you speak?
No, Hindi, Marathi, English, and understand Punjabi, Sindhi,
Gujarati.
Gujarati.
Which language?
Find Marwadi and the other Western language is a little tough to understand, but these three I can understand.
In which language has the choicest four-letter words, according to you, which you would use in your mind when you're terribly upset?
I don't usually use them, but if at all, yeah, it's Hindi only. Hindi, maybe Marathi.
Okay.
Bhadava comes, sorry, easiest.
Easiest. Donald Trump,
Yeah.
good, bad, ugly.
Is there anything?
Worse than that. No, we can stick to.
No, we are, sorry, I mean, we live in Kalyug, we live in interesting times. It's a good thing that we are not his subjects, so chodo. Though, I'm sorry, I'm not right of center. So I'm definitely left of center.
Left of center, yeah.
Yeah.
Next life ka profession, if there is a next life.
This has been a good life. This has been a good life.
You would repeat
I have
that.
been privileged to be, in the broad sense, a physician.
क्या बात है?
I mean, you think back, how many millennia of history we have. Our ability to do good and to earn a good living. I have no regrets, and I don't believe in afterlife. We are random bits of protoplasm on a random planet in a random universe. Once we are gone, we are gone.
Wow. So you are an atheist, you would say?
Completely.
Complete atheist. Okay, let's begin with some more formal geriatric neurology first. So we are doing two things, geriatric neurology and end-of-life care, which may not contain neurological subjects. So first of all, sir, we'll do Parkinson's disease, if you're okay with us.
Yeah.
How does a family physician suspect idiopathic Parkinsonism early in the disease?
So typically the rest tremor is the most typical thing. So if you look at tremors,
Sure, yeah, I can hold your mic.
if you look at tremors, so some people will come with tremors on both sides, especially when they are. So this is an essential tremor. This runs in families. Very rarely this goes on to become Parkinson's. The rest tremor is, the hand is resting and it trembles, right? So one side, and that starts off typically on one side. So somebody notices, or they're walking and somebody sees them from a distance, and says, "Thoda sa alag chal raha hai, aur haath thoda hil raha hai." Right? So walking becomes a little slower. This hand starts to tremble. And for you, when you check them, again, you have to, yeah, okay, give me a hand. Yeah, you can see this. So on the side which is abnormal, you do this and compare it to the other side. Ek part cut, and the other one goes smoothly. That's it. That's Parkinson's. So typically we are looking for 4 things: rest tremor, slowness, stiffness, and in some patients, inability to maintain balance. So loss of postural writing reflexes. And there's one more which we use and which I think should always be there in the back of your mind, that when you start levodopa, straightforward levodopa, I'll come back to that.
Yeah.
I'm okay, na?
Please.
I'm kind of...
No, you're not jumping. That's
Yeah,
okay.
so when you start levodopa, and just remind me to give you a bit of a tip on that. When you start levodopa, the patient should come back 1.5 months later saying, "Wah, jadoo ho gaya."
So remarkable response to
Good response.
dopamine.
Good response, literally to the point of normalcy. Of course, there will be patients you will pick up who will be very early in the course who are not, who says, "Arey yaar, my wife is chewing my brains. Mere ko to koi takleef nahi hai." Leave him alone.
You can get away not treating.
Yeah, in fact, it's a slow disease. It will take months, years before it gets. So I always tell my patients that with Parkinson's, that unlike diabetes and blood pressure where I can see a number and treat, here you have to tell me that it is bothering you. मैं काम नहीं कर पा रहा हूँ. So obviously somebody who's retired and is just wandering around the house, you may delay treatment. Somebody who's sitting in a board meeting and worked up, you might want to treat earlier. Typically when you start the medicine, the standard preparation is the +1. So Syndopa plus, Tidomet plus, there are 3-4 other brands. The plus is labeled as 125. It's 100 plus 25. Start with half a tablet twice a day after food. Then 1 tablet twice a day after food after 10 days. And then 1 tablet 3 times a day. Once it is settled in the stomach, they are not running into problems, then you shift it to activity-wise. सुबह 6 बजे उठते हो, पहली गोली सुबह 6 बजे. दोपहर को 1 बजे खाना खाते हो, 12 बजे second tablet. Because you then time it to activity before food and before food. So both these things are important. But you do it only after they are comfortable with the medicine.
So just a corollary question. Does delaying treatment because the patient is not very uncomfortable change the course of disease for the worse?
Not at all.
Correct.
Not at all.
So
this is something that has had enough research.
Correct. So again, just repeating a little bit. He said that give after food for first few days because GI intolerance is a significant problem for 1.5 to 2 months. And absorption of Syndopa is better on empty stomach. Therefore, switch to empty stomach after the tolerance has been established by the patient. That's a great tip. When should they stop treating and send to a neurologist? They have.
So one is, of course, if the patient is not doing well, not responding well, symptoms are too much, side effects are too much. And you must remember that 20% of these patients will either have a poor response or no response. Those are the atypical Parkinson's or the Parkinsonism plus, right? Progressive supranuclear palsy, corticobasal ganglionic degeneration, and multiple system atrophy. So just remember them as atypical Parkinson's or Parkinson's plus. Some features that are common to them is, one thing is that they are more symmetrical, except corticobasal, which is completely asymmetrical. So if you see idiopathic Parkinson's disease, it's asymmetrical but bilateral. Completely asymmetrical to the point that one hand becomes like this is CBGD. Completely symmetrical is PSP. And in PSP, which is the most common of them, they start to fall. They climb downstairs and they fall backwards. They get up from the chair and they fall sideways. You see them sit down in their chair and they go, thump. Literally. And their eyes also begin to move slowly. That's a much more difficult disease.
So to make it more accessible to them, so PSP, he said, is the most common form of atypical Parkinson. PSP stands for progressive supranuclear palsy. And this is a small percentage of total Parkinsonism. So when will you suspect PSP, because this has to be immediately referred, he said bilateral onset. Is that correct?
False and false.
And false would be the two clues that you may be dealing with atypical. Do they have similar tremor? Because tremor is what they will want to even think of Parkinsonism.
At the age of 75, just a question for the audience. At the age of 75, how often, anywhere after the age of 70, how often do you think people fall? What is the normal figure? What beyond which you will start saying, boss, garbad hai kuch? Sorry? No. साल में कितने बार? Two. Anybody who falls more than twice in a year and any random cause. Because finally, how do you fall? You fall when you misjudge and you're not able to compensate. Right? So basically, loss of compensation is loss of postural writing reflexes.
So that becomes one feature of suspecting
something is happening.
Something is happening.
And please, when you say something is happening, there are enough times when I see a patient and say they come in, something is happening, I can't give you a disease yet. आपको बीमारी चाहिए तो 1-2 साल बाद आइए.
Yeah.
No, literally, you have to say that, no? That, and when you approach a patient like this, you make sure you have not missed out. B12, thyroid, check their vitamin D, pump it up, because if you can't stop them falling, at least you can strengthen their bones. And there are some specific MRI indicators of neurodegeneration which you need to be aware of. We are now picking them up more and more often. Now we are picking them up early also, which is also a danger. But anyway, but when you see one of this, you say, कुछ हो रहा है. क्या हो रहा है? अभी तक नहीं मालूम. And then, frankly, for that, my only answer is physiotherapy.
Nice.
Stay active, do physiotherapy.
Balance.
Keep coming back.
Since you are demonstrating tremors, can I take the liberty of asking you to demonstrate the gait of Parkinson's, if you can? No, difficult. Okay.
I'm a bad dancer. So
Okay.
there was a senior GP from Bandra who used to demonstrate gaits brilliantly. He's
Yeah.
no longer.
I'm sure there will be videos that you can see for gait of Parkinsonism. One Parkinson's variant that they will see is drug-induced Parkinsonism. And they are more and more aware of drug-induced, but what warnings can you give the GP?
Which drug? Done. So if I see rabeprazole L or pantoprazole L, my
Antenna go up.
antenna go up. Or somebody who's taking Stemetil for months or Stugeron for months.
Cinnarazine, that is.
Cinnarazine,
Prochlorperazine.
yeah, and and Leosulfide.
Leosulfide, yeah.
And of course, psychiatry medicines, of course. But then the psychiatrists usually pick them up before anybody else.
Correct.
So there, typically, it just is a little bit of slowness. Tremors and the other features of Parkinson's actually come in if somebody already has an underlying tendency to Parkinson's and that gets
Unmasked.
unmasked. Otherwise, they just become a little slow. So people start saying, कि अरे ये बराबर नहीं चल रहा है, ये थोड़ा धीरा. And then you look at the drugs and you realize it.
Yeah, I'll just, sir said 3 drugs, leosulfide, cinnarazine, and your Stemetil, with this prochlorperazine. Yeah. What is the reversibility of leosulfide-induced Parkinsonism?
Fairly decent.
Very decent. So you can get off the drug and get better.
Okay. But more often than not, it's convincing the patient that they need to stop it. Because they say, नहीं, मेरे को तो acidity है, मेरे को ये तो, and typically you find that the acidity is nonsense. I mean, they've got migraine, they eat rubbish or do all kinds of funny things and they want to take tablets.
In a standard 65 plus onset of Parkinson's, idiopathic Parkinson's disease, what do you give them as expectancy of health span?
As of now, if I see somebody at 60, I say, you will be with me till I retire. No, so typically when you look at Parkinson's, it reduces the lifespan. It reduces the lifespan by a certain amount. The younger you start off, maybe a little more. So if it starts in the 30s, then yeah, they will be in severe problems by the time they are in their 60s. But if it starts off in the 60s, yeah, they'll be late 70s, 80s before it really bothers them. And if they start off in their 70s, I tell them, yaar, goliyan khao, don't worry about it.
Don't worry, yeah.
The worst are the ones in the 50s because they are still active when it starts hitting them. 40s and 50s is when it's bad news.
Okay.
I mean, even 30s is bad news, but 40s is really bad news.
If a person who starts in the 50s becomes, say, bedridden by the 70s?
So typically, see, what is happening is now you start them off on medications. For at least about 10 odd years, they do fairly well.
Okay.
Aage piche. You need to start preparing them for if they are middle class and above, preparing for the stuff, the hardware that we use that really make a difference. Deep brain stimulation. Then there's a lot of research going on, there's a lot of stuff going on, so you'll really need to be aware of what is possible. But deep brain stimulation adds a good 8-10 years.
8-10 years.
Yeah, yeah.
Wow.
So if somebody is in that, say, 7th, 8th year running into problems, medicine, deep brain stimulation, they will function well for another 10 years.
So I'm sure they will want to know what is deep brain stimulation. Can you summarize it for us?
Yeah, so basically the pacemaker is actually put here with the battery and everything. Leads are placed into the basal ganglia, and the exact placement is still kind of evolving in a given patient, maybe little different. So you really need one of the people who's experienced to do it. But the expertise is now very widespread. And it's a pacemaker.
And in what patients is it indicated, if you can tell them?
Right. So once idiopathic Parkinson's disease starts,
So your whiteboard, yeah.
so this is something that's a little tricky to understand, and I'll explain that to you. Marker? Yep. So when we are giving levodopa, the part of the brain, the basal ganglia, has a certain capacity to take up that levodopa. I mean, see, this is going to this small part of the brain. You're swallowing that drug and you're hoping that enough reaches there. Now, when it reaches there, it has to cross a certain level to become effective. And once it crosses that level, it causes side effects. Side effects are like this: excess movements. If it drops below this level, then it loses its effect.
Sir, mic closer to mouth.
Sorry, it loses its effect, right? So when you start treatment, you are well within this channel. But you can see what is happening towards the end, right? I mean, I should have drawn these more equal. But towards the end, what happens is they have these motor fluctuations where you give the tablet, in about 2 hours or so, the effect is gone. And they are stiff. And then you give the tablet and they are dancing. So if that starts to happen, then that is the time to move on to deep brain stimulation. When will that happen? Between 5 and 10 years. Some people might be unlucky, might happen earlier. Some may be very lucky, it might happen later, but that's a ballpark figure.
How many centers do deep brain stimulation in Mumbai?
So this changes, because depending on people
Expertise.
moving, some corporate picking up people from Hinduja and taking them elsewhere. That happens. Yeah. So, at the moment, Hinduja, Jaslok, Kokilaben, Wokhard, yeah, I think they've also started. So, Reliance, of course, Reliance will do everything.
That is
Jio DBS आ जाएगा कभी ना कभी.
GODBS.
Yeah.
Just the ballpark cost and whether covered in insurance.
15 lakhs, 15 to 20 lakhs.
Do you think it is covered by insurance?
I'm sure that there will be some package which covers it, but as of now, difficult to imagine that it's completely covered by insurance. But what I tell my patients is start putting aside a kitty of at least 10 to 15.
So this is what you should tell the patients also, that this is a possibility after some years and make a reservation for that. Maybe आपके टाटा स्टील के शेयर उधर जाएंगे या कुछ तो
Yeah, fair enough, correct.
हाँ रिलायंस के ही पड़े हाँ so
You never know if Rahul Gandhi becomes Prime Minister.
किसी ने बुक किया
Yeah, they'll become friends.
what is the life of a DBS pacemaker
So,
lead?
the key thing is the battery. Typically, once it is put inside, that stays inside. But the battery,
Change.
there are rechargeable ones and so on. So, the cheaper one is the one that needs to be replaced.
Okay.
There's a actual incident that I went through. So, there's a patient of mine referred, Dr. Sankhe is the neurosurgeon who was at Hinduja, got the patient in, got the pacemaker installed. She was living alone, but very independent. Even though she was in her 70s, she wanted it. Ho gaya. And I mean, we'd of course done a proper medical evaluation and everything. 2 days after surgery, she was quite excited and walking around. Just died.
Died.
Died. Obviously, we're not certain whether it's a myocardial or... we don't think it was pulmonary embolism because that we had checked for. So I had the job, together with Dr. Sankhe, of actually going to their house and removing the battery.
Wow.
One, because the battery would have exploded in the pyre. And second, we asked them, do you want to waste it? Gave it to, we put it in a poor patient.
Yeah.
Yeah, so somebody who has major psychiatric or cognitive issues. So one thing more to remember about both Parkinson's, all kinds of Parkinson's, is that towards the end, dementia also sets in. So almost 80% of patients with Parkinson's will have dementia towards the later part of the course.
Yeah. Does DBS, I'll repeat the question because they don't have a mic.
DBS, typically if it is very pure tremor, now the technique that's coming up is lesioning. You can just put a single lesion right at the appropriate spot, and some people are even doing that with focused ultrasound. But it's also done with direct stereotactic, and there are other multiple techniques that are coming up. So pure tremor lesioning is good enough, probably, but that an expert only can. I don't even get into that. Yeah, that's 20 lakhs.
What she's asking
20
is...
lakhs.
So
No.
I'll just
No.
reframe the question, sir. She asked, does DBS help rigidity, hypokinesia, swallowing? Does DBS help?
So, if somebody has already reached the stage of swallowing issues, then it might not be a good idea.
To put.
But you never know, because so very often eating is about other things as well, and you don't know whether they're shaking and not able to swallow, whatever. It's worth considering. If the patient is motivated, then I would definitely ask one of the movement disorder neurologists to take a look and make a judgment.
Okay.
The point, this judgment is to be made by a neurologist, not by the neurosurgeon. Parkinson's. Idiopathic Parkinson's disease has a heritability, I think, of about, I'm not sure, but I think about 10%. But you have to remember that all these neurodegenerative diseases, if they begin in their 40s, 30s and 40s, then there's probably a genetic component. The later they begin, the less likely that the genetic component is big.
Correct. Any tips for them that we have missed so far for the GP in managing Parkinson's? Or any end-of-life advice?
Yeah. So please, I'll pass it on to him, but once we have these documents, the document I've already told you, ideally, these should now be in your clinics, outside.
Printouts.
Printouts should be outside, so that if anybody says, and we will also run classes, explain to you how to use them, but at least put them out. Let's start people being aware. I tell people that the way you require vaccination as a child, you require this kind of education towards the end of life. It's like a vaccination. Yeah. You avoid suffering towards the end if you take charge. So the worst suffering is when there is, because doctors are like, okay, families, I don't want to be, pointed fingers at. So who takes decisions? Nobody takes decisions. And then you get stuck in the ICU on ventilators, which nobody wants. So somebody has to take the decision. It's your body, you have to take that decision. So maybe that's one way to explain it to patients, and that's for a Parkinson's disease, maybe about 5-10 years into the course. आपने बनाया है क्या नहीं बनाया तो देख तो लो एक बार.
Correct.
And sorry?
He's asking how to treat insomnia in patients of Parkinson's. Or how to treat depression, which is sometimes a part.
Depression, typically I use escitalopram. If there is no cognitive impairment, then amitriptyline, nortriptyline also work well. They're not a good choice if they already have a little bit of memory impairment. But otherwise, escitalopram is the safest.
And for
5
sleep?
milligrams
Yeah.
in the morning. If they're drowsy, shift it to the night. After 10 days, increase it to 10 mg. If they still feel they can benefit a little more, maybe go up to 15. Beyond 15, psychiatrist.
And sleep medicine?
Sleep medicine, first of all, again, try and pull out printouts on sleep hygiene. You will get them across, or keep a downloadable link on your wherever you have it and tell them to look at it. First stop is sleep hygiene. Second stop is melatonin. Melatonin 3, 5, maybe even a little more, but at 7 to 8 p.m., not at bedtime. Next stop is benzodiazepines, whatever. And even when I give benzodiazepines for one of the drugs, I tell them, it depends. I mean, if it is somebody in the 80s, who cares? I mean, you might as well take it every day and have a good night's sleep. But in younger people, I tell them, don't take it more than 2 or 3 times a week. Strict limit, not more than twice or thrice a week.
Correct. Okay, I'll go.
Sorry?
Hallucinations of Parkinson.
Okay, so hallucinations in Parkinson's, dementia. So you have to distinguish between hallucinations due to psychiatric disorders, which are a psychiatrist's business. Modi is speaking to me and telling me all kinds of funny things. He says funny things, but that's a different thing. So whenever you have somebody, thought control and all those symptoms, that's psychiatric. But if you have a person who already has Parkinsonism and dementia, so typically these are problems in perception. And they start off gradually. It starts off with, "Arey, koi tha kya? Arey, wahan se billi gayi." Right? Gradually it increases. And then, "Ye kaun hai idhar khada hua? Ye usko jaane ko bolo." "Arey, ye sab itne sab log kaise aa gaye? Cupboard ke upar bandar baitha hua hai." So these hallucinations start to become more and more formed. Small objects or shadows, small animals, humans. Eventually, obviously, if it gets to the stage of threatening, then it becomes a little bit of a danger. So I have this patient with Parkinson's who has hallucinations and who has insight. He knows, मला माहित आहे ते नाहीत आणि त्यांना सांगितलं ते जातात. पण कोण आहे? ती एक बाई आहे, ती नेहमी येते, तिच्याबरोबर तिचा नवरा आहे, तो कधी कधी येतो. So he's actually got these stories in his mind. And he knows it's not true. So when he's put on clozapine, because he's got Parkinson's, I couldn't use anything else. When he was put on clozapine, they disappeared. And we are down to the point where they turn up, te आता संध्याकाळी एकदा येतात. ठीक आहे, fair enough. You're okay with that? Yeah, येऊ द्या, चालेल. I'm not worried about them.
So again, not all hallucinations need to be treated.
But if you warn them, okay, this is the way it will go. The family also needs to know, the patient also needs to know, and then you can figure out. So, okay, I'll cover this other topic. And this is something that I'm a little particular about. It's whenever you have behavioral problems in either, actually in anywhere, in any situation, even in our own home and everything, use the ABC technique. Whether it's an irritable child, whatever. What is the antecedent?
Antecedent.
What is the behavior? A, B, and what is the consequence? So antecedent is anything that you do. I mean, somebody is bothering them about nahaya nahi, ye nahi kara, wo nahi kara. Behavior is irritable shouting, right? Consequence, the one consequence that is not permitted is physical violence.
Violence.
So if that is happening, then you have to intervene. Otherwise, you have to explain to families कि अरे यार, especially in dementia, ये तो बच्चा है अभी ना. You use a little bit of emotional support, you little bit of coaxing. Otherwise, नहीं ना है तो क्या फर्क पड़ रहा है? You're bothered. Is he smelling? No, he's not smelling. Leave it.
Yeah.
So antecedent, behavior, consequence, and families don't understand that this framework, and judging, you start with what is a consequence. If the consequence is a guy is stinking and hitting people, yeah, then you need to do something. But you need to be able to judge your responses and not overdo it.
Nice. Sir,
Sorry?
we will actually go ahead because we are
Yeah.
running short of time. So we'll take more questions as we go along. There's a lot of things to do. Next, I'm coming to a topic where we family physicians make mistakes, a lot of mistakes. And I want to discuss those and how we can correct them. The biggest mistake we make is in the pharmacotherapy of delirium. And I would like you to teach us. Delirium, as you know, can occur due to so many medical problems like hyponatremia or multiple infections in the elderly, etc. And if the patient becomes aggressive or unduly stuporous, meaning drowsy, we become very, very aggressive, especially the aggressive patient.
Okay, so delirium is, in that sense, a pretty huge topic because look at delirium in terms of the basic, it's acute brain failure. Dementia is chronic brain failure. So acute brain failure, so somebody is chalta firta individual becomes acutely delirious, then it is a medical emergency. Absolute medical emergency. And the way to understand that, yeah, good. Sorry. Think of this in terms of somebody's level of normalcy function is this. So, I mean, 0 is of course nothing. And severity of illness, right? A young, healthy, or a healthy individual will get delirious only when the severity is meningitis. Or maybe, perhaps a little older, maybe pneumonia, right? But a older individual who's already got dementia, even sardi khansi will make them delirious. Or UTI is the classic example of an old person becoming delirious, right? So you have to kind of understand that the severity of the precipitating factors and the vulnerability of the brain. Put these together, you get an idea. Typically, the one thing that we do, which worsens delirium, are drugs. And the drugs are, there's a scale called anticholinergic burden. Actually, you look it up and it keeps evolving. They're also called Beer's criteria for drugs. Typically, some drugs are bad. So for instance, Pacetane. It will very easily give you delirium. But some drugs are less. So again, the same way, you have a person who's vulnerable, will go down with one medicine. You have somebody who's less vulnerable, go down when you have 3-4 medicines. And if there is one message that I want you to take home is that as GPs, you have the responsibility of looking at their medicines. No consultant will do it. They will just add another 5 medicines. And if you look at an old person, the family is saying, 25 dawaiyan hai. And the old man is busy popping, aaj maine ye khaya, aaj maine wo khaya, aaj maine wo khaya. So it is worth the effort of some time, if it's an old patient, regular patient saying, bring everything. Ye kisne diya, kyun diya, kai ko diya. And it's basic common sense. Stuff that is not required, just knock it off.
So what he is saying is that in a patient with acute, delirium is always acute. In a patient with delirium, check the cause. If the cause is infection, you have to treat the infection. You don't have
Drugs.
to give haloperidol or whatever you give, antipsychotics. And of course, remove drugs, especially those who have an anticholinergic burden. And we as family physicians realize that the prostate medicine given by the urologist also has an anticholinergic element, and the cold medicine given by somebody else also has an anticholinergic function. Amitriptyline has an anticholinergic. So many drugs have anticholinergic properties. So, as he said, Beer's criteria, for example, says 2 anticholinergics are enough to cause trouble in the senior citizen. So that is something that you might want to check.
So Beer's criteria, you will locate them, take a printout and keep it around so that, I mean, if you're a little, I'm never sure. So I look at the drugs, arey, isse ho sakta hai kya? You get that. And obviously, you will first of all send off a CBC and a sodium and create SGOTPT. Basic stuff you will send off immediately. So between these 3 things, you should be able to pick up.
Yeah. In geriatric pharmacotherapy...
management, sorry, there was a question about management. Okay, so management. Typically, what I would recommend is somebody has dementia and is getting aggressive and you've done this and you've not found anything, then I would use haloperidol. Just be sure that the person doesn't have rigidity. Because Parkinsonian features, because sometimes people will have both, not sometimes, very often. And if they have Parkinsonian features, they will deteriorate very rapidly with haloperidol. If they don't, I mean, you can make out. This is smooth. Person has nothing up here but is able to walk perfectly well. Which actually is a bigger problem because they are mobile and aggressive. Then use haloperidol. And the way I give it is 0.5 milligrams 3 times a day. This is thanks to Dr. V.K. Mundra who trained me on this. So 0.5 to 1 milligram 3 times a day for 2 days, that quietens them down immediately, bring it down to 0.5 BD, bring it down to 0.5 HS, bring it down to 0.25 HS only. Minimum strength, 1 tablet, you can keep it going for a couple of weeks, maybe even a month. But 2 days, you can quickly bring it down. It works very well. So but be sure that there is no Parkinson's.
Yeah, so just to summarize what he said dementia patient with acute psychotic features where they are aggressive, maybe you will use haloperidol orally and you'll take care that there are no Parkinsonian features because first generation antipsychotics like triaxiphenidil, like Serenase, worsen Parkinson's. And also, once he said before this, that if you have to give antipsychotics in a person with Parkinsonian features, then risperidone is not good, quetiapine is not good. You have to use...
No, quetiapine you can use...
Clozapine is, you said, choice.
Most effective.
Most effective.
I mean, at the family physician level, I would not use clozapine, I would use quetiapine. Quetiapine I would use.
Less Parkinsonian side effects.
Fairly safe.
Okay. Quetiapine
25 to 50 mg HS, you can go up to, I think beyond 50 I would refer, but if you're confident, maybe even up to 100 you could go.
Quetiapine. I will repeat his question because the audience cannot hear. He's saying that patients become very drowsy even with small dose of quetiapine or Serenase.
So if they are naive to sleep medicines, then you always start with half dose of... and warn them. If the person has not slept 2 or 3 days and sleeps full 24 hours the first day they get to sleep, what is so special about that? It will pass off. But warn them.
Correct. We'll go to the next topic, and that next topic is your favorite area, which is epilepsy.
Sure.
He is, of course, an expert. What is your interest in epilepsy like?
No, so it's clinical epilepsy, making a diagnosis, starting medical treatment. I used to work with epilepsy surgery also, but then found that, I mean, that was getting a little too much. So now it's, at least at Hinduja hospital, there are other people who do it.
In geriatric seizures or geriatric epilepsy, tell us what are the commonest causes of convulsions or first convulsion in an elderly patient? Commonest cause of first convulsion?
Stroke, past head injury, and low sodium.
Commonest causes of seizures.
Yeah.
And can stroke present with a seizure without any focal deficit?
Very rare.
Right. So stroke would be easy to identify.
They've had a stroke in the past and now they get a seizure. Or they've bashed up their head, maybe had a motorcycle accident 20 years ago and now they get a seizure.
So this is scar epilepsy.
Yeah.
But what about an acute stroke causing a seizure?
Presenting with a seizure? No.
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 a TIA or a stroke will not present with a seizure.
In fact, if somebody comes in with an actual seizure, then we are preparing for thrombolysis, that's one of the
Contraindication.
no, it's one of the red flags that you start looking for other things.
Other things, okay. Past history of stroke, hemorrhagic or ischemic can cause today epilepsy.
Yeah.
And that epilepsy might be focal.
Or generalized. Often the first episode, because there is no drug on board, can be generalized.
So again, for the family physician, if there is a seizure for the first time in a senior citizen, they will do an MRI to look for an old stroke.
So it depends. Again, about the scans, if you are in an emergency, then a CT scan is as good as an MRI, and it is quicker to get because the patient is not restless. 5 minutes mein andar bahar. The CT scan gives you enough information. But the one thing to watch out for is if the patient looks like if they're having a stroke, then do not do any investigations except sugar on the spot. Send them to a stroke capable hospital immediately because literally every minute they are losing brain. If they are affording, I mean, if it is somebody who's completely out of the slums, then just do a CT scan and start aspirin, maybe. But if they are affording, and even for somebody very poor, there are times when KEM hospital also does manage to do some very good work. So remember that. It depends on the profile of the patient and so on, where you send them. But if they are even a little affording, send them to one of the private stroke capable hospitals. And as of now, I would think that any hospital of, say, Bombay Hospital, Jaslo, Wockhardt, Hinduja, all hospitals are now capable of
Managing stroke.
managing this.
So I'll go back to seizures and then come back to stroke. You said seizures can be due to hyponatremia or hypoglycemia also maybe. Can the family physician treat any kind of seizure at home if once the seizure has passed?
Yeah, so what kind of first aid do you advise for seizures? How? No. So the first thing is, I mean, presuming that you land up on the scene, you are called. 90% of the times the fit is over. I mean, but if it happens just outside your clinic, the first thing is you time it.
Oh.
Yeah, so a full generalized tonic-clonic seizure is the borderline of land of physiology and pathology. The brain has mechanisms to stop it.
Mm-hmm.
If those mechanisms break down, they break down at 3 to 5 minutes. So somebody, and you can see, I mean, either say, itne aane mein, and patient is still going like this, just rush them immediately to hospital. At the most, give midazolam intramuscular. Don't bother with an IV line. Intramuscular midazolam, if you have it on the spot, obviously not everybody keeps it, but if you can keep it in the fridge, that is one thing to keep. Intramuscular midazolam, 5 milligrams for a child, 10 mg for an adult. Intramuscular. That is very erratic. It's more for non-doctors. But I mean, if you are a doctor, you are carrying parenteral midazolam intramuscular. That will hold them until they get to the emergency and status epilepticus treatment can start. Because once 5 minutes are crossed, then it is status. Right? And this has now been proven in a trial where they gave paramedics in the ambulance IV, which is lorazepam and intramuscular midazolam. And they felt that midazolam won because you didn't have to waste time setting up an IV. You just shot it and...
So that...
Sorry?
Per rectal paraldehyde, etc.
किसके पास paraldehyde है?
I think...
frankly, I mean, good luck. You're trying to find how to put it in. Sorry.
How much time will intramuscular midazolam take is the question.
It's usually effective within a few minutes, up to about 5 to 10 minutes. See, it buys time. You're going to an emergency in any case. It buys that much time, kind of holds off the status until they get into the emergency and an ICU and all that.
So our lesson to learn is in your bag, visit bag, 1 10 milligram midazolam
5 mg
vial
का
has
रहता
to
है,
be there.
5 mg के दो.
5 mg ke do.
I think it's available as a 5 mg.
I have a 10 mg.
Oh, you
so
have?
I have.
Wow.
So, my brother has epilepsy. So 10 mg का रखना है. And
It has to stay in the fridge. It can't stay.
अच्छा नहीं रख सकते, मैंने रखा है. Okay.
So
It has to stay in the fridge. So मैं उस brother के घर पे रख दूंगा फिर. Okay. We come back to stroke. Stroke, we have learnt about stroke early action to be taken from various sources. So just a few pointed questions for your. I have often told them that a telephonic consultation might be more time saving than the patient coming to your clinic, and maybe a video call will identify a stroke. So can you tell us, can we do that?
Okay. So typically for laypersons also, what we use is the face, arm, fast. You know that. So they can't speak, the arm doesn't stay, they can't stand or they're falling, and the face is twisted. 2 out of 4 is enough to make a diagnosis.
So this can be done on the telephone. Patient
Yes.
का phone आया या relative का phone आया कि कुछ ठीक नहीं है, and you look at the patient. If the face is looks like there's a palsy there, the speech is not good, arm cannot be held. You can't see the legs on the phone, maybe, but the arm, or if the patient cannot stand,
Yeah.
that is enough for you to say that this is a stroke. And what is the instruction given to them?
You should know which is you should be able to grade the hospitals in your area. So if you are somewhere between, say, Mahim to the other or whatever, poor patient KEM, rich patient, you know where.
Yeah. So how do you, meaning, do they call the neurologist? What is the code that is activated?
Ideally, like Hinduja has a stroke code. So as soon as they land up in the casualty, if the CMO thinks it's a stroke, I think I've got a SMS right now.
Oh.
So the SMS goes to everybody. And the resident on call drops everything, goes there first. You do not contact the neurologist.
Okay.
Do not. I mean, if it's a hospital that needs you to contact the neurologist, don't go there.
Acha.
Yeah, simple, no? Because, अरे वो कहाँ है, phone उठाया, नहीं उठाया क्या?
Yeah.
We've had this issue. We've had this issue in Hinduja hospital where one of the consultants said, nahi, this resident is on call, but he's with me right now on the rounds. I said, nothing doing. He's on call today. He goes down now. And then, वो मेरा patient है, मेरा patient नहीं. He goes down, he starts treatment and then asks, which doctor?
Correct.
Yeah, because otherwise you're losing time in all of this, no?
So for thrombolysis, as you know, the time limit is 4.5 hours currently.
You would not wait till 4.5 hours. The faster, the better.
Limit, huh?
We call it door to needle time.
And what happens when there's a wake-up stroke? Meaning the patient wakes up, the stroke is already there. When the patient wakes up, you don't know at what time in the night the patient had a stroke. So now what is the criterion?
I think it would still be good to send them to, again, one of the stroke-capable hospitals.
Okay.
And again, let them run the patient through the same system. We have the same system even for wake-up strokes.
And there are certain MRI sequences that can differentiate
Yeah.
the timing of the stroke.
Yeah.
So
In fact, there are now papers coming out where they are doing thrombolysis even as long as 24 hours.
Wow.
Depending on what you find and so on. So there's stuff that is possible. Especially thrombectomy is now possible up to 24 hours for hemispheric, which means straightforward paralysis, but definitely for basilar artery strokes. So whatever time.
You can. So just to make sure, basilar
More than 24 hours and
the problem. Okay, that will come to them sometimes where the patient has spent more than 24 hours or is coming from a village, comes to them with a hemiplegia, dense hemiplegia. Now, what is their
If the patient is
consultation?
stable and it's been some time, then the imaging of choice is the MR angiogram. That will give you all answers. I would also probably do a 2D echocardiogram and an ECG, pick up any cardiac issues. If it's an infarct, then start off with, in the initial period, aspirin and high-dose statin, 40 or 80 milligrams of atorvastatin at least for the first 10 days. And then decide, I mean, how you want to, depending on whether a physician is accessible to you or neurologist. I don't think you really need to go to a neurologist in this. Yeah.
One thing that they have a problem with is when they do go to a neurologist, the neurologist will often prescribe a stroke patient a dual antiplatelet therapy, and sometimes that dual antiplatelet goes on. So what is their de-prescription recommendation?
Okay, so typically dual antiplatelets, this is not very clear cut depending on how the stroke has been caused. So we call it, I mean, the neurologist should tell you the mechanism of the stroke. So mechanisms of stroke, one is lacunar. You understand lacunar stroke?
Tell us.
So lacunar stroke is 2 out of 3. Face, arm, leg, only 2. Okay? And that too pure. So face and arm motor, or face and arm sensory. Right? So one function and 2 body parts. No aphasia, no fits, nothing else. Pure small stroke. For this, I would probably give a single antiplatelet. Dual antiplatelet, definitely not longer than 10 days. Full dose statin, maybe for also 10 days. And then drop them to aspirin and basic statin dose. That is lacunar stroke. Sorry? 75. 75 is good enough. 75, 150, I mean, we don't always use it. Then second is large artery thrombotic stroke. Okay, so the MR angiogram picks up, say, the person has a right-sided hemiplegia. And on the angiogram, they are telling you that there is disease, either in the ICA or the MCA. Now, this needs more intensive treatment. Here, we would give dual antiplatelets. Again, bit of judgment, maybe up to a month, maybe even up to 3 months. And high-dose statin, again, for probably about a month. And again, this is a patient where intervention might be thought of. Right? So here is the patient where you really wonder. Sometimes, of course, the stroke is so bad that the story is over. In which case, within a month, you can drop back to
Single
aspirin and statin. But I mean, if it is, say, a medium-sized stroke and the worry is that there is much more of the brain left that can still be damaged, then you need to be careful. Right? Sorry?
No, high-dose statin for 1 month, then the...
That is when you have an
standard dose.
arterial lesion, because the statin is required to stabilize the plaque, no? Okay, again, whenever you see somebody on statin, do you do a basic checkup after that? Because physicians don't do it, neurologists don't do it. I normally do it. I ask for a lipid profile after a month on a stable dose. Not on 40 or 80, there's no point. But when somebody is on 10 or 20, I definitely do.
We have recommendations in ASCVD, established ASCVD, you have to bring the LDL down to 70.
Yep.
So that is necessary.
Do you also check the CPK?
Only if patients have significant myalgia, we don't do CPK or SGOT-PT as a standard thing.
Tick.
Okay, something about just one more thing on
No,
stroke.
so I hadn't finished that.
Sorry.
Sorry. This was large artery stroke. The third is cardioembolic.
Yeah.
And the problem with cardioembolic stroke is that the angio is clear, this is a medium or a largish stroke. You have to look for the smoking gun. The smoking gun is a heart lesion that could have fired. So it could be LV enlargement, LA enlargement, LA enlargement more than 4 centimeters. If it is 4.5, definitely you will worry about it. Atrial fibrillation, if you don't find any of these, then a Holter, if that picks up,
Arrhythmia.
P8, paroxysmal atrial tachycardia, anything, then again that becomes a smoking gun. And there's also the chats too, I won't go into that. But these are decisions that either a physician or a neurologist need to make whether to put that person on long-term anticoagulation or not.
So just to get the basics, he was talking so far about antiplatelets.
Yeah.
Now if there's a cardioembolic stroke, that means thrombus in the heart has thrown an embolus in the brain. Now you need anticoagulants, and oral anticoagulants like NOACs may be necessary.
Apixaban is what we normally...
Standard would be apixaban.
Yeah.
Okay. She's asking if primary prophylaxis with ecosprin is something that is given in any situation.
What do you say?
I'm an anti-primary prophylaxis of ecosprin. So
Yeah.
even in diabetic patients where there used to be a recommendation for aspirin as a prophylactic.
The only exception is, say, I've done an MR angio for something else, for migraine, and I find,
Thrombus.
some kind of a, no, even
Disease,
atherosclerotic
atherosclerosis.
disease. Then that's actually going beyond primary. I mean,
Yeah.
so somewhere between primary, which is actually something has happened, and primary where nothing has happened, and secondary, there is this in-between gray area of subclinical.
Post-primary prophylaxis. Okay, so what the common problem that we face, because a lot of patients come with coronary CT angiograms, coronary CT, and there are plaques 30%, 40%, and then the argument is that the plaques can rupture even before they become 100%. They can at 30% rupture and cause infarction. So why not give aspirin to prevent platelet aggregation? No studies have been done. So if we want to wait for studies, we should not give aspirin. If you don't want to wait till the patient dies, you may give aspirin.
Remember, but that is not your decision.
Yeah.
That has to be the patient's decision.
Yeah, it is.
Because if they say, no, I don't want that risk, and I get a bleeding ulcer, sure, you decide it.
No,
So
but
there are some things that you have to leave the patient to decide. Your job is to advise.
And you give knowledge, because
Knowledge.
the incidence of even hemorrhagic stroke is known in primary prophylaxis. Statistics are known. Numbers needed to harm are known. So you can check that up and may let the patient say, okay, मेरे family में history बहुत है तो मैं तो लूँगा, तो ठीक है.
Hardly ever. We use it only for DVT prophylaxis.
Correct. What he's asking is actually, he's not sending the patient to a stroke unit. He doesn't like that. He wants to give treatment, thrombolysis in his clinic. He's in a remote area or runs an ambulance service and he wants to give treatment. Is it allowed?
You would need to be trained. There is training available for that. We generally do accept, if MD physicians can manage stroke in remote areas, why can't a GP manage? But you have to train yourself for that.
It's not difficult. I think
Yeah.
the training is possible where you can manage a stroke with thrombolysis, up to thrombolysis.
Yeah.
Acha, what is the drug used?
Tenecteplase or alteplase, this varies. It depends on cost. It depends on the individual comfort, various things. Yeah, tenecteplase is good. There's enough studies on it now.
No, he's coming from this place. We are all 60 plus. We have seen little thrombolytic therapy in our younger age. And our, belief in thrombolytic therapy has not yet become like a significant belief. Should all patients be forced by us to go for thrombolysis if they are in the time frame, is the question.
So the thing is that I would insist on an evaluation stat. Even if the patient is completely normal by the time they've come to you, I would insist on an evaluation stat. So if the patient is completely normal, neurologist ka appointment nahi mil raha hai, whatever, get an MR angiogram done at least. MR angiogram, not just plain MRI. It has to be MR angiogram. Yeah, I would get an MR angiogram done. We are in India. We are not in the US where an MRI costs $1,000.
God knows.
How much? You, gali gali mein hai MRI, yaar. You don't, I mean, you don't want to then be faced with this guy coming back next 1 week later saying, तुमने मुझे बताया नहीं और ये हो गया.
So tell them, sir, about TIA recurrence rate statistic.
So TIA is typically is a transient ischemic attack. Earlier we used to say 24 hours. Now even 32, 1 hour is probably acceptable. These things are changing. But you typically have those that actually show an abnormality on the MRI and those that do not. So small infarcts versus something that has not caused an infarct. Again, it also depends on whether the angiogram and the investigation pick up a smoking gun or not, right? It also depends on what that patient is like, diabetic, hypertensive, not. So all of those things you need to understand. And at the end of that period, then you have to make your decisions about treatment. Say if it is a 35-year-old man who's anxious and always worried and the MR angio is normal, I would probably do nothing. But in a 75-year-old, I would at least put them on aspirin. I mean, even if I don't find anything anywhere.
No, I'm talking about if, just a second.
Sorry,
if
did I miss the question?
If a patient comes with a hemiparesis, which lasts for 20 minutes,
yes,
elderly maybe, you do the evaluation including heart workup, etc. What is the statistical incidence of a second event occurring within, say, 1 week?
Okay, sorry, I missed that part of the question. So typically, again, it depends on what you turn up on the investigations.
Yeah.
So if you turn up, say, an arterial lesion and an actual infarct, then the risk is fairly high in the first 24 hours, up to about a week, and then it drops. But even in the first week, it's only about 20%.
20%?
20 to 25%. Again, it varies. Individual patients will be more or less. Once you've crossed about 3 to 4 weeks, then it drops down to about somewhere between 5 and 10%. Once you've crossed the first couple of months, then it is 5% or less for the rest of the year. So it's a risk that is highest in the beginning. I might let you know that, and this is something that is also to do with the economics of our profession. You will have people who will come in 2 months after their stroke. They have an angio, and somebody is telling them, "Isko stent dalo, isko stent dalo, isko stent dalo." Your job is to be the protector of the patient.
So again, indications of stenting are?
Indication of stenting and surgery are both roughly equal. They are usually, again, best done in the first. Many people don't like doing it immediately after. So, because again, there's a hemorrhagic risk, but typically in the second week or so.
So what we are talking about is like the coronary artery, there are significant lesions. There can be significant lesions in the carotid artery. And common carotid, internal carotid, both can be affected?
Internal carotid more.
More internal carotid. And if the patient has had a stroke related to an artery to artery embolization, and the patient has recovered from that stroke, but there is this 80% stenosis, then whether to leave it alone, whether to operate it with an endarterectomy, or whether to dilate it with a stent and put a stent, is a decision that has to be made and individually and with the help of a neurologist, not an interventional neurologist.
And yeah, not the person who does it. जिसके हाथ में छुरी है उसको मत पूछना.
Yeah.
Simple. And more importantly, you also have to take into account the person's own risk-bearing capacity.
Yeah.
If they say, it's okay, I don't want anybody touching it. The last is actually a little trickier, and that is again where the neurologist will probably be useful to make a decision. In his institution, who is the better operator? Whose results are better? Yeah?
Sorry, he's asking, in a patient who's comes in acute stroke, in cardiac patients we give full dose 325 aspirin and say 180 Brilinta. What is your dosing?
So there is
Should they give in the OPD?
So there is some trial evidence that when there is, say, a significant stroke and you're not intervening or doing anything else, and there's a lesion that could fire again, then 300 mg of clopidogrel. Loading dose of clopidogrel has been used. But I think that these are all, this is all research and literature that's evolving, that's changing pretty fast. No. At the moment, I would give 150 mg aspirin and stop.
If the patient is within the thrombolysis window, do you give aspirin?
You could give aspirin. There is no harm to giving aspirin. Yeah.
Okay, we'll break for tea.
Sorry? So 75, you won't have killed him. Don't worry about that. See, if you can, I mean, look at it this way. The stroke is in front of you. You're sending them to the hospital. Right? If they're going to the hospital, they will get a scan done as soon as they come in. And that decision will be made. Half an hour is not going to make that much of a difference either way. So don't. Don't. I mean, the patient may not be able to swallow, you'll have trouble, then the family kind of gets worked up. Don't.
Okay,
the better thing is to just move.
I'll just go to the hemorrhagic stroke part, because then we can discuss blood pressure with the hemorrhagic stroke and the ischemic stroke. The commonest cause of hemorrhagic stroke in any country is hypertension.
Correct.
And India has a lot of hypertensive patients.
Correct.
Are you seeing proportionate incidence of hypertension-related hemorrhagic stroke increasing?
No. I mean, these are I think roughly the proportions and numbers are the same that I saw at the beginning of my practice and now.
So, vis-a-vis ischemic stroke, what is the percentage of hypertensive hemorrhages?
I think 10 to 15% is
much less.
Yeah, much less. It's there.
It's there. Right.
See, we are getting better at controlling hypertension, but we are getting worse on pollution. So, I don't think we've changed too much.
Correct. If a patient comes with a hemorrhagic stroke, a IC bleed, which looks like a hypertensive IC bleed, what is the blood pressure target that you in the hospital look at?
If it is in the range of hypertensive encephalopathy, then you need to get it down. But typically, we would get it down to about 180 systolic. And diastolic, you can wait. 24 hours is good enough to gradually bring it down to. There are people who have looked at targets of even lower, 150 or lower. But it's almost like a shallow curve. There's an optimal which is somewhere between 150 and 180. You'll find literature changing. So
why I'm asking this, though this is a hospital-based question, is many patients, if they are in the hospital with hemorrhagic stroke and you kind of visit them or they call you कि भाई BP अभी भी 180 है and BP की वजह से hemorrhage हुआ है, so you have to pacify them that okay, we have to keep the BP at a certain level, otherwise lower BP will harm what does it harm? The penumbra?
Yeah, so basically the brain has gotten used to, its autoregulation is disturbed. It's gotten used to higher blood pressure to maintain its circulation. So you drop it too fast and you can cause damage.
Okay.
So once upon a time, you saw something like this and you would give them sublingual nifedipine. Now nobody's does that.
Yeah. So in high blood pressure, sublingual nifedipine is out. Correct?
Yeah.
What about ischemic stroke? If the patient comes with 170, 100 in an ischemic stroke situation?
No. Leave them as they are. Because it's the body trying to push blood through the block.
So even if they come to your clinic with a hemiplegia and a BP of 190, 110, you don't touch the blood pressure and just send them to the hospital. Is that right?
Yeah, correct.
Okay. Another thing about post-discharge, ischemic stroke discharged, stable patient, what is the blood pressure control, or hemorrhagic stroke, what is the blood pressure control?
So the regular limits that we are now beginning to accept, below 130, 140, below, definitely below 90 diastolic, closer to 80, those apply across the board, but you have to be a little more strict. In fact, these are patients who probably will benefit from having a BP instrument at home.
So now you have to become a little more aggressive in controlling blood pressure after stabilization, after discharge. Now you don't accept even 150/90. Now you have to become a little more in stroke patients. A little bit about atrial fibrillation. We are probably a lot of hypertensives, a lot of obesity, a lot of diastolic heart failure, or what we call HFpEF, is being seen in India. And therefore, probably atrial fibrillation is being detected more. Anything to prevent the first TIA or first stroke by any study? The watch, the smart watch. Okay, you keep the patient, or do you suggest any periodic, like we do a periodic stress test, a TMT, any periodic Holter?
You'll have to ask a cardiologist, but I don't think there's the yield of a Holter has been. It's now, everything is moving to wearables.
Wearables.
So if you worry about it, then a wearable is probably better than, how long can you keep the Holter on in any case?
Correct. True. So but you do think that in your practice, your patients have come with detection through wearables?
No. Mine is, after they've missed the cardiologist, the GP, the cardiologist,
then they come to you. Correct. She's asking a hypertension question of pharmacotherapy. What is your opinion on generally antihypertensives good for preventing stroke, and whether aldactone is better?
No, I don't think I would have any opinion on that. Whether you use amlodipine, use telmisartan. Finally, what matters is the BP number.
Okay. I'm going, before our tea break, which is in 20 minutes, I'll do one short topic. And that short topic is the topic of geriatric, in geriatric neurology, how to apply the principle of start low and go slow. In neurology, in geriatrics, we have this principle.
Yeah, correct.
And within neurology, I'll just give you examples, and you have to give us practical tips. So if you use gabapentinoids in peripheral neuropathy, painful neuropathy, post-herpetic neuralgia, how do you start a gabapentinoid? Do you prefer it over, say, amitriptyline, or how do you start amitriptyline?
So this is a broader question. I mean, you're looking at treating neuropathic pain.
Correct.
And the choices are between tricyclics, duloxetine on one side and gabapentinoids on the other side. Now, between tricyclics, I prefer tricyclics. There are a lot of people who use duloxetine. I prefer, if they have a sleep problem, amitriptyline. If they don't have a sleep problem, nortriptyline. Nortriptyline in the morning, amitriptyline at night. Amitriptyline, start at 10 mg. Typically give it at dinner, not at bedtime, because otherwise hangover. 10 mg, if they are not done with, if they are comfortable with 10 mg, but still not fully benefited, then go to 25, except that in older individuals, you start worrying about constipation, little bit of retention, you check if they have glaucoma. All those things you need to be sure about, and then you can go up. But if all of these are passed, then these are my favorite drugs. Okay, and then comes gabapentinoids. Again, some people use gabapentin, some people use pregabalin. Gabapentin, I typically start at 300 at bedtime, and then every 3 to 4 days go up. So 300, 2 HS, then 1 in the morning, 2 at night, 1, 1, 2, 1, 2, 2, 2, 2, 2. Okay, so gabapentin in painful neuropathies, people have used up to 3,600 mg in an adult.
Wow.
Yeah. So if you go gradually, people do tolerate it, but you have to be sure about what you're doing. Same thing with pregabalin, more expensive, Uh, this is something that I didn't know earlier, and that is that pregabalin has multiple brands. I am told that the original brand apparently is an
Lyrica.
S or whatever enantiomer, which is more effective,
Superior.
or at least has less side effects. But it is also much more expensive. So typically I use one of the Indian brands, but if they run into side effects, then I go back to that. Again, there I start at 75 mg HS. 2 HS after 3 to 5 days. I let the patient decide. If they're not sleepy, they can increase it after 3 days. If they are sleepy, then wait for 5 days. 2 HS, 1, 0, 2, 1, 1, 2. Again, 1, 1, 2 is the maximum that our patients tolerate, though in literature you can go up to 600 mg.
The other drug that is
Then again, come back slowly down.
while stopping, he's asking.
Yeah, come back down slowly. So again, I tell them that if at the end of a month, month and a half, you don't think this is working for you, then the way you had stepped it up, the same way you take it off.
The next area of start low, go slow is in the palliative care area. Opioids. So first of all, tell us the role of opioids in the pain ladder. What is your opinion? Where do you start?
Typically, in the pain ladder, see, I'm a neurologist. I have a certain amount of training in palliative care, but if we are moving on to morphine, then I call in the palliative care people. So I won't be able to advise that. Typically, I will use paracetamol, full dose. Full dose meaning how much?
4 grams.
4
maybe.
grams they say, but I think
Elderly will be
yeah,
little
about
less.
2 to 3 grams is safe enough. 4 tablets of, more importantly, not at least QID, because
Space
other
them.
duration action. Then you add an NSAID, then you go on beyond that. If it is more neuropathic, and very often it is mixed pain, so then you add one of these other drugs, and so on. But once I start heading into
Opioid territory.
opioids, then I usually call it.
Course.
Ultraset, of course, I use, but beyond that, I usually call in
Correct.
palliative care people.
Right. We have one quiz for you. So,
Me?
okay, this is a rapid fire in pharmacology
Okay.
of geriatric neurology. And we'll discuss each point in a little bit also.
Yeah.
Your one drug of choice for trigeminal neuralgia.
Carbamazepine.
Your choice of steroid in Bell's palsy.
Prednisolone,
Do you use acyclovir in Bell's palsy?
of course.
Your favorite neuralgia drug, you already mentioned.
Yeah.
Your favorite multivitamin. How multi can it be is also a question.
So, the way I look at it, this is what I take. So, I take one of the B12 folic acid combinations. I can tell you the brand. Tetrafol Plus, I think Sun Pharma ka hai, but there are others that are similar. So, I take that twice a week. And vitamin D, the 60,000 unit capsule, I take twice a month.
Okay.
By the date.
By the-
And my numbers, my B12 is usually about 600, 700. My vitamin D is about 50, 60.
Your favorite drug for orthostatic hypotension? Midodrine, fludrocortisone.
Both. Start with fludrocortisone, then go on to midodrine.
Your favorite sleep medicine if you have to give a benzodiazepine?
Alprazolam.
Your favorite Z drug? Zolpidem. Zolpidem. Your favorite anti-epileptic in an adult? Senior citizen?
Phenytoin.
Wow.
No, so, okay, I'll explain this. So if you have somebody who has epilepsy, not bad epilepsy, medium epilepsy, they are not on any other medications because interactions are substantial. Ideally, you have covered them in vitamin D. Phenytoin is a fire and forget drug. You give them 200 mg at night and call them after 2 years.
Acha, that effective.
Yeah, I mean, before all these others came on, we learned how to handle phenytoin, and even now, you give them vitamin D with it, But for an elderly person, it is a very good drug.
Wow. And as you said, it has polypharmacy-related drug interactions. So if a patient is
Yeah,
on
so if multiple
polypharmacy,
drugs, then I wouldn't use ferritoid.
correct.
And also, I would not use oxcarbazepine in the elderly person.
Hyponatremia,
Not just hyponatremia, false.
false.
Yeah.
So, your favorite drug for restless leg syndrome?
Okay, complicated. So I would first of all check their iron status. If the
Iron
iron status, including ferritin, not just iron studies, but also ferritin, and then make a decision. First, simple, just give them iron. No?
Correct.
If it is low, just give a single dose of IV iron, instantly you'll get an answer. And then I would start with pregabalin knowing that pramipexole is probably more effective. But pramipexole, typically once they start on that, then it starts to build up. So
what he's saying is that pregabalin, gabapentin can be given in RLS, pramipexole, roperinol can be given in RLS, once iron is not the cause, and probably he thinks that pramipexole side effects when the dose is escalated. Is that right? Side effects?
not just side effects, I mean, it tends to escalate.
Escalate, okay. Sorry? What the term used is augmentation.
Yeah, sorry, I should have used that word.
Okay.
Yeah. Augmentation. Okay. But the problem is that there are some patients where it is a family, it is an autosomal
Familial,
dominant condition and they really have bad RLS. Then there's no choice. I mean, there's again, the literature is changing. There's, if anybody is interested, I'm happy to share the latest review articles and whatnot.
No, that will be useful.
Reasonably safe, but then again with due caution.
Correct. Okay, that is your rapid fire.
बस कुछ हो गया.
दूसरे सब्जेक्ट्स में बाकी कवर होगा. ठीक है, sir. I think if you can check Kumar whether tea is served or not. Ready? Okay. Depending on the tables that are serving tea, half of you or full of you can go and have tea. Yeah. Okay. Sir, हो गया? चलेंगे?
चलो.